Most doctors treat tinnitus like one single disease, a hopeless static ringing you must learn to live with. The shocking truth is that this approach misses the real causes in the majority of patients, and that mistake changes lives. After more than 2 decades in ENT practice, Dr. Michael Golenhofen found that roughly 80% of people with troublesome tinnitus fall into 3 distinct, clinically identifiable subtypes. When you recognize which subtype you're facing, diagnosis and treatment stop being guesswork and start being targeted care. Dr. Golenhofen isn't talking theory, he's describing a practical clinical map: a cortical or stress-related type driven by attention and brain filtering, a somatosensory type driven by jaw or neck inputs, and a cochlear type tied to damaged inner ear hearing. Each needs a different pathway, and alarmingly often patients get the wrong first step. That's the part patients remember most, being told to learn to live with it without a real investigation. That's the part clinicians can change right away. Think of tinnitus not as a single disease, but as a symptom, like pain. Pain can come from an injured joint, nerve compression, or stress-amplified sensitivity in the brain. Tinnitus behaves the same way. If you treat noise in the ear with only one strategy, you'll miss the driver. If you start with a careful history, a few simple bedside maneuvers, and targeted tests, the next steps become clear. If someone has ever told you just live with it, comment yes below and keep listening. This message is for patients who feel dismissed and for clinicians who want a clearer pathway. We're going to walk through how to spot the 3 main types: what to ask, what to order, what to avoid, and where interdisciplinary care makes the difference. Why differential diagnosis matters more than we admit. The conventional pattern in many clinics goes like this: patient reports ringing, clinician runs a standard audiogram. If hearing is normal, the patient is reassured or told to adapt. If hearing loss is present, hearing aids may be fitted and the rest is left as chronic care. 2 problems hide in that workflow. First, a normal audiogram doesn't rule out non-cochlear drivers. Second, even when hearing loss is present, hearing rehabilitation is not the whole answer. Some patients still need counseling, and others need dental or neck-focused interventions. Clinical experience and emerging practice patterns suggest that about 80% of stubborn tinnitus cases can be categorized into 3 subtypes. Why does that matter? Because each subtype has different diagnostic cues, different urgent flags, and different first-line treatments. When clinicians use the wrong pathway, for example reflexively giving steroids for unilateral tinnitus with cochlear signs, patients can experience delays, unnecessary interventions, and avoidable distress.
This isn't criticism of individual clinicians so much as a call for systematic change, more precise histories, a few bedside tests many people don't know about, and routine interdisciplinary referral where indicated. That shift alone can convert "learn to live with it" into "let's investigate and treat what's driving this." The first subtype: cortical, attention, stress, and the filter that went offline. Definition and mechanism in plain terms. Cortical or stress-related tinnitus is essentially a problem of attention and central processing. The auditory system normally filters and deprioritizes harmless internal sounds. Under intense stress, or when attentional control collapses, that filter can deactivate. The brain starts amplifying an internal signal that had previously been background noise. The result is a tinnitus perception that is often bilateral, diffuse, fluctuating, and tightly bound up with distress. A simple analogy helps. Imagine a small whistle hidden at the back of a busy kitchen. When the kitchen is quiet and your attention narrows, that whistle feels loud and impossible to ignore. When you're focused on something else, cooking, talking, sleeping, the whistle is present but not disruptive. Cortical tinnitus becomes a problem when stress or sleep loss increases vigilance towards sound, and the brain's off switch for that whistle gets stuck. A vignette that illustrates the pattern. Anna, 42, came to clinic after months of constant high-pitched ringing. She had no history of ear infections or head trauma, and her audiogram showed only mild, age-appropriate high-frequency loss. The tinnitus began during a period of acute stress, a job change, a sick parent, and poor sleep. She described the sound as everywhere, sometimes louder when she lay awake at night, and sometimes barely noticeable during busy daytime hours. She had no jaw pain, no recent dental work, and no single-sided onset. Key diagnostic clues you can elicit in the history. Onset after a stressful life event or during a period of poor sleep. Bilateral or diffuse perception rather than a clearly lateralized single-tone whistle. Strong emotional reaction and focused attention on the sound. The patient can describe how attention feeds the tinnitus. absence of sudden unilateral onset, pronounced hearing asymmetry on audiogram, or somatic modulation, i.e., jaw or neck movement changing the tinnitus. Fluctuation in intensity linked to sleep, caffeine, or anxiety levels. What to test and expect to find. Standard pure tone audiometry may show no major asymmetry, often only high-frequency loss, if any. Speech-in noise or central auditory processing screening can be informative if available. No consistent somatory modulation on jaw or neck maneuvers. Screening questionnaires for anxiety, depression, and sleep disturbance are often positive and useful to guide supportive therapy. Initial management priorities. Counseling and explanation come first.
Patients need to understand that the perception is real, but that distress and attention are amplifying it. Reassurance alone isn't sufficient. It must be paired with a practical plan. Defocusing strategies, structured exercises that train the brain to shift attention away from the sound. For example, scheduled sound enrichment or attention training tasks. Explain these as retraining the brain's filter rather than blocking the symptom. Evidence-based counseling approaches, including cognitive behavioral techniques focused on changing the relationship to the sound rather than promising elimination of the sound. Sleep and anxiety management are cornerstone adjuncts. Short-term, targeted medications may be appropriate for severe insomnia or anxiety, but stress that these are symptom management tools, not cures for tinnitus itself. Avoid overprescribing medications as a primary tinnitus therapy. Antidepressants or anxiolytics can ease comorbid conditions and thereby reduce tinnitus distress, but they should be used with clear goals and follow-up. Active referral to psychological support or structured CBT programs for patients with high distress or functional impairment. Clinician tips for patient conversations. Start by validating. I hear how much this is affecting you. This is a very real experience, and we can make a plan. Then map the clinical pathway. Because your audiogram doesn't show a clear asymmetry, and this started during a highly stressful time, it looks like a stress-related or cortical tinnitus. The best first steps are counseling and strategies to shift attention and sleep optimization. We can add targeted medications for sleep if needed, but those are just part of the support plan. That sets expectations while offering hope and a concrete plan. What to avoid. Saying there's nothing to do or implying permanence. Validation plus a plan is essential. Promising that psychotherapy or sound therapy will eliminate the tinnitus entirely. Explain likely outcomes. Reduce distress, improve sleep, and restore daily functioning. Using sedating medications as a long-term primary approach with concurrent behavioral strategies. Mini hook before moving on. One history question changes the diagnostic trajectory more often than any other. Did this start during or after a uniquely stressful period or a sleep collapse? If the answer is yes, you're likely in the cortical pathway, and the next steps are counseling and attention retraining, not antibiotics or steroids. The second subtype, somatosensory, when jaw and neck inputs hijack the hearing system. What's different here and why it matters. Somatosensory tinnitus arises when sensory input from the jaw, TMJ, teeth, or cervical spine alters brainstem processing and creates or modulates a tinnitus percept. The key feature is modulation. Jaw clenching, moving the neck, or certain dental contacts can change the loudness or pitch. This is not rare, and it's frequently overlooked because standard ear-focused exams miss the dental and cervical contributions. A prototypical vignette. Mark, 35, woke one morning with a sudden, high-pitched tone in his right ear after a weekend of intensive teeth grinding. His audiogram was essentially normal. During the visit, when he clenched his jaw, the tone intensified. When he opened his mouth wide or pushed his jaw forward, the sound shifted in pitch. He'd recently had a crown placed on the same side. He had no vertigo, no facial weakness, and no significant hearing loss on standard testing. Key diagnostic cues to ask about. Sudden unilateral onset, especially in the absence of audiometric change. Clear somatic modulation, alteration of the tinnitus by jaw movement, teeth clenching, or neck positioning. Recent dental work, occlusal changes, or jaw pain. History of bruxism, teeth grinding. Recent neck trauma, whiplash, or chronic neck pain. Pain or clicking in the temporomandibular joint. Essential tests and targeted imaging. Begin with a careful jaw and neck exam. Palpate the TMJ, reproduce modulation with jaw clench open maneuvers, and assess cervical range of motion. A standard audiogram is still important, but a normal result with clear somatic modulation points away from cochlear origin. Request dental imaging when history suggests dental involvement. An orthopantomogram, panoramic dental X-ray, is often the first-line image to screen for root issues, malocclusion, or prosthetic changes that could be influencing sensory input. If dental or TMJ pathology is suspected, targeted referral to a dentist or orthodontist for occlusal assessment is appropriate. Consider osteopathic or physiotherapy assessment for cervical contribution. Why steroids are the wrong reflex here? A crucial pitfall is reflexive steroid prescribing for any new unilateral tinnitus. Steroids and hyperbaric oxygen are indicated pathways when there's evidence of acute cochlear injury, typically sudden sensory neural hearing loss confirmed on audiometry. In somatosensory-only presentations with normal audiogram and clear jaw-neck modulation, steroids are not indicated and may expose patients to unnecessary side effects without benefit. Correctly identifying somatosensory modulation changes the entire treatment pathway toward dental, orthopedic, and manual therapies. Initial management approach. Coordinate with dental colleagues. If dental occlusal change, prosthetic issues, or root pathology is suspected, treat that source first. Use conservative manual therapy, osteopathic manipulation, physiotherapy focused on neck and jaw, and TMJ-directed exercises can reduce the aberrant somatosensory input. Consider dental guards or bite adjustments for bruxism where indicated. Short-term analgesics or muscle relaxants may help manage associated muscle tension, again as symptom tools rather than cures.
Audiologic support. Sound therapy and counseling remain useful to manage distress while somatic issues are treated. Clinician checklist for somatosensory suspicion. Unilateral onset plus normal audiogram? Check. Modulation by jaw or neck movement? Check. Recent dental procedure or neck trauma? Check. If these are present, order dental imaging, orthopantomogram, consult dentistry, orthodontics, and include osteopathy or physiotherapy in the referral plan. Explicitly avoid steroid pathways unless the audiogram demonstrates a true cochlear change. The diagnostic pivot most clinicians miss. Too often, a normal audiogram triggers either reassurance or an assumption of central tinnitus, but the presence of clear somatic modulation should redirect the clinician toward dental and musculoskeletal assessment. This pivot stops the cascade of inappropriate steroid prescriptions and opens up effective targeted interventions. A short audiologic support. Sound therapy and counseling remain useful to manage distress while somatic issues are treated. Clinician checklist for somatosensory suspicion. Unilateral onset plus normal audiogram? Check. Modulation by jaw or neck movement? Check. Recent dental procedure or neck trauma? Check. If these are present, order dental imaging, orthopantomogram, consult dentistry, orthodontics, and include osteopathy or physiotherapy in the referral plan. Explicitly avoid steroid pathways unless the audiogram demonstrates a true cochlear change. The diagnostic pivot most clinicians miss. Too often, a normal audiogram triggers either reassurance or an assumption of central tinnitus, but the presence of clear somatic modulation should redirect the clinician toward dental and musculoskeletal assessment. This pivot stops the cascade of inappropriate steroid prescriptions and opens up effective targeted interventions. A short clinical sidebar on somatosensory modulation. Not every patient who notices an altered pitch when clenching is due for a dental referral. Physiologic modulation exists. Many people hear slight changes with jaw movement without an underlying pathologic driver. The difference is a supportive history, sudden unilateral onset, persistent modulation linked to a clear event, dental work, trauma, bruxism, or associated TMJ pain. Those are the cases where targeted imaging and specialty referral matter. Mini hook before the next section. If your tinnitus moves when you move your jaw or neck, that single observation can reroute your care entirely, and it's often the one clue that changes everything. Beginning the third subtype, cochlear, when the ear itself is the driver. Why this remains classical ENT territory. Cochlear or hearing loss-related tinnitus is the form most people intuitively imagine. Tinnitus arising where the inner ear, cochlea, is damaged or losing function. It often coincides with measurable hearing loss and responds at least partially to hearing rehabilitation strategies like hearing aids or, in severe cases, cochlear implants. Acute cochlear insults, such as sudden sensory neural hearing loss, are medical emergencies because timely intervention can salvage hearing and reduce persistent tinnitus. Urgent flags that mandate immediate ENT action. Sudden onset unilateral tinnitus accompanied by a measurable hearing loss on audiometry. Rapidly progressive hearing loss over days to weeks. Associated vestibular symptoms like new vertigo or balance changes. When these red flags are present, the pathway often includes urgent audiometry, immediate ENT assessment, and discussion of corticosteroid therapy and possibly hyperbaric oxygen within the early window where they have the best chance to help. Vignette, an ENT urgency case. Sarah, 58, woke with a roaring in her left ear and significant difficulty hearing on that side.
Her tuning fork test raised alarm, and pure tone audiometry showed a marked sensory neural loss at multiple frequencies. She presented within 48 hours. This scenario triggers the acute cochlear protocol, urgent ENT assessment, and consideration of systemic steroids, intratympanic steroids, and discussion of hyperbaric oxygen based on availability and timing, where hearing rehabilitation becomes central. In chronic cochlear-related tinnitus, where hearing loss is stable and the tinnitus coexists, hearing amplification is often transformative. Hearing aids restore missing input and can reduce central compensatory changes that amplify tinnitus. For patients with severe bilateral loss, cochlear implants have been shown to reduce tinnitus for many recipients. Counseling and sound therapy still play a role, particularly when residual distress remains, but the primary lever is restoring auditory input. What to measure and how to prioritize. Comprehensive audiometric assessment, air-bone conduction, speech audiometry, and if available, extended high-frequency testing. Tympanometry and otoscopy to rule out conductive contributors. For acute unilateral cases, compare baseline if available, and repeat audiometry quickly to assess progression. When hearing rehabilitation is being planned, speech-in-noise testing and real ear measures inform hearing aid programming to optimize both hearing and tinnitus masking or sound enrichment. Limits of medication for chronic cochlear tinnitus. Medications do not reliably cure chronic cochlear tinnitus. For acute cochlear injury, systemic or intratympanic steroids are the mainstays within the appropriate time window. For chronic management, the role of pharmacologics is largely symptomatic, sleep aids, anxiolytics, or antidepressants to manage comorbidity, but they are adjuncts rather than primary treatments for the tinnitus itself. Transition and the clinical synthesis we'll return to. So far, we've outlined the three core types: cortical, stress-related, somatosensory, TMJ neck, and cochlear, hearing loss. Each has distinct clues, tests, and initial treatments. In practice, many patients present with overlap. A person with mild hearing loss who is stressed and also grinds their teeth may have drivers from 2 or even all 3 categories. That's where coordinated care matters most. Prioritize the driver of distress while simultaneously addressing contributing factors. Before we pull the threads together, a practical list of questions clinicians should ask in the first minutes of the visit. When did the tinnitus start? Was it sudden or gradual? Is it one-sided or both-sided? Does it move when you move your jaw or neck? Any recent dental work, head or neck trauma, or new medications? Any associated hearing changes, fullness, dizziness, or neurological symptoms? How is sleep? Are you experiencing high levels of stress or anxiety? What makes it better or worse?
Positions, sounds, activity. These questions, simple as they are, rearrange the differential in most cases and point to which tests and referrals should come first. A practical diagnostic flow to keep in mind. Sudden unilateral onset plus audiogram change. Treat as acute cochlear problem. Urgent ENT. Consider steroids or hyperbaric oxygen. Unilateral onset plus normal audiogram plus jaw or neck modulation. Assume somatosensory cause. Dental imaging and musculoskeletal referral. Avoid steroids unless cochlear changes emerge. Bilateral, diffuse onset after stress or sleep collapse. Assume cortical or stress-related. Prioritize counseling, defocusing, and sleep or anxiety management. Consider short-term meds for symptoms only. What happens when clinicians miss the pivot? 2 common missteps keep repeating. First, defaulting to learn to live with it for anyone with a normal audiogram. Second, reflexively prescribing steroids to any new unilateral tinnitus without confirming cochlear change. The first abandons patients who could benefit from counseling or somatic interventions. The second exposes patients to unnecessary systemic therapy and delays the correct specialty referral. Both patterns contribute to the shocking truth that systemic gaps in assessment, not the intractability of tinnitus, often determine outcomes. We'll continue by unpacking practical, stepwise management for each subtype, the specific counseling phrases that normalize without minimizing, the exact jaw and neck maneuvers to test for somatosensory modulation, how to choose imaging, and when to involve dentistry, physiotherapy, or psychology. We'll also explore the role of interdisciplinary clinics, how to use brief referral letters to speed collaboration, and what patients can bring to appointments to make those first consultations productive. We'll continue by unpacking practical, stepwise management for each subtype, the exact phrases clinicians can use to normalize without minimizing, the jaw and neck maneuvers that reliably demonstrate somatosensory modulation, choices of imaging and when to order it, how to draft a focused referral letter that speeds collaboration, and how patients can show up prepared so the first visit is productive. Throughout, the organizing spine remains the 3-subtype model. Use it to prioritize investigation and treatment rather than defaulting to a single pathway for everyone. Practical counseling scripts that work. One of the simplest changes clinicians can make is how they open the conversation. Validation followed by a concise plan reduces panic and increases engagement. Try this structure. Empathize, name the likely pathway, outline next steps. For example, when the history fits a stress-driven cortical pattern. I understand how distressing this is.
From what you're telling me, it started during a very stressful period and feels like it's everywhere. This most commonly reflects the brain's increased attention to sound rather than damage inside the ear. That's an important distinction because our first steps will be counseling and retraining attention, plus addressing sleep and anxiety. Those measures often reduce how much the ringing interferes with daily life. That sentence validates, signals a likely diagnosis, and gives immediate hope along with concrete next steps. For somatosensory suspicion, the script is different. I can see how alarming a sudden one-sided tone is. I want to check whether movements of your jaw or neck change the sound. If they do, that suggests a jaw or neck input altering how your hearing pathway is processing signals. If that's the case, dental or musculoskeletal treatment often helps, and steroids are not the right first step unless we find hearing loss on your audiogram. This sets a clear diagnostic expectation and prevents reflexive steroid thinking. For a likely cochlear case where hearing loss is present, because your audiogram shows a clear asymmetry and the tinnitus started suddenly, we treat this as a possible inner ear injury. That means urgent assessment and discussion of treatments that can protect or recover hearing. Acting quickly gives us the best chance to help. Here, urgency is framed with purpose and avoids alarmist language. Simple verbal scaffolding like this reduces the nothing can be done feeling and anchors the patient to an evidence-based pathway. Exact bedside maneuvers and what they mean. Clinicians who add 2 to 3 focused maneuvers to a standard ear exam dramatically improve diagnostic yield. Describe and record what you find. Jaw maneuvers. Endogenous modulation test. Ask the patient to clench their teeth firmly and note any change in loudness or pitch. Next, have them open widely and then protrude the jaw. Observe and document whether the tinnitus increases, decreases, or changes quality. If clenching significantly alters the tinnitus, that's a strong somatosensory clue. Lateral jaw pressure. Apply gentle pressure to the mandibular joint while the patient reports tinnitus change. Reproducible modulation with manual TMJ palpation supports a TMJ-related input. Neck and cervical maneuvers. Head rotation/extension test. Ask the patient to slowly rotate their head to each side and extend or flex the neck. Note reproducible tinnitus changes with specific positions. A clear positional modulation suggests cervical somatosensory contribution. Scapular and cervical muscle activation. Ask the patient to shrug and tense neck muscles. Observe for change. Active muscle contraction that alters tinnitus is another somatic marker. Tuning fork and simple auditory checks. Tuning fork lateralization. For clinician ears, quick Weber and Rin checks still have value to screen for asymmetry at bedside. Speech-in-noise screening. If available, a brief speech-in-noise test gives functional insight beyond pure tone thresholds and can suggest central auditory processing issues relevant for cortical subtype. What to document? Always record whether modulation is present, which maneuvers change the sound, the laterality, and whether the audiogram shows any asymmetry. That documentation is what makes targeted referrals meaningful rather than vague requests. Imaging choices and when to order them. Not every patient needs imaging. Think of imaging as targeted troubleshooting when specific red flags or structural clues appear. Orthopantogrammogram, OPG, panoramic dental X-ray, use when history suggests dental change, recent crown, implant, root work, bruxism with prosthetic changes, or persistent unilateral somatosensory modulation. OPG screens for root pathology, impacted teeth, prosthetic misfits, and gross occlusal relationships that could drive TMJ sensory input. TMJ-specific imaging, CBCT or cone beam CT, MRI of TMJ, consider if OPG shows abnormalities or if clinical TMJ signs, clicking, locking, significant pain, are present, and invasive dental or surgical interventions are contemplated. MRI is best for soft tissue analysis, discus displacement, while CBCT provides high-resolution bony detail. Cervical spine imaging, reserved for patients with neck trauma history, clear cervical radicular signs, or refractory cases where physiotherapy fails and structural lesions are suspected. Plain radiographs or targeted MRI based on clinical suspicion. Neuroimaging, MRI brain with contrast, indicated for true red flags, asymmetry with progressive neurological deficits, pulsatile tinnitus with vascular suspicion, focal neurological signs, or when the auditory symptoms are accompanied by imbalance and objective findings. MRI is not a routine test for everyday tinnitus without red flags.
A principle to remember: imaging should be hypothesis-driven. The key question is always, will this image change management? If not, defer. Referral letters that clinicians actually open. A tight one-page referral beats a long narrative every time. Whether you're an ENT writing to a dentist or a primary care clinician writing to ENT, include these elements in the first lines so the recipient knows why this case matters. Start with a single-sentence clinical summary. 35-year-old male with sudden right-sided high-pitched tinnitus since X date. Audiogram normal. Tinnitus loudness and pitch reproducibly increase with jaw clench. Then add 3 brief bullet points. 1. Relevant clinical tests already performed and results. Audiogram date and summary. 2. Key history. Recent dental work, bruxism, trauma. 3. What you are asking for. Orthopantogrammogram and dental occlusal assessment, or TMJ specialist opinion. Close with a question. Would you consider targeted dental or orthodontic evaluation and possible bite assessment?
I can share audio clips and modulation test recordings. This format conveys urgency, avoids duplication, and facilitates collaborative action. Why audio and modulation recordings matter. Encourage clinicians to use simple smartphone or clinic-recorded audio samples and written modulation descriptors. A 2-second notation like clench plus 3/10 loudness or a short patient-recorded clip demonstrating modulation is far more persuasive than a vague description. TinyCare's clinician letter PDFs are designed exactly for this. Concise one-page summaries that include suggested wording and space for key test dates and results, a practical tool to speed collaboration. Targeted pathways, how to sequence referrals. For somatosensory cases with clear dental correlation, order OPG first, then dental or occlusal specialist if abnormal. If OPG is normal but TMJ signs are present, consider TMJ-targeted imaging or referral to a maxillofacial specialist. Simultaneously, involve an osteopath or physiotherapist for cervical muscle evaluation. Many successful plans combine dental correction and manual therapy. For cortical, stress-driven cases, prioritize psychological or CBT referral and consider audiology-led sound enrichment programs while screening for comorbid insomnia or depression. Medication for sleep or anxiety can be initiated short-term with clear follow-up and exiting strategy. For cochlear presentations with acute audiometric change, expedite ENT assessment, begin documenting the audiometric trajectory, and discuss steroid protocols and hyperbaric oxygen referral if within the therapeutic window. Time matters. The diagnostic sequence should be rapid. Medications and adjunct therapies, realistic framing. Patients often ask if a pill will stop their tinnitus. The correct clinical framing is, medications can reduce comorbid symptoms that amplify tinnitus, anxiety, insomnia, muscle spasm, but they rarely cure tinnitus itself. Use medications as targeted, time-limited tools. Sleep and anxiety agents. Short-course sedative hypnotics or low-dose sedating antidepressants may be appropriate to restore sleep in severely affected patients. The goal is functional restoration, not indefinite pharmacotherapy. SSRIs or SNRIs can be indicated when comorbid major depression or generalized anxiety disorder is diagnosed. They can indirectly reduce tinnitus distress. Muscle relaxants and analgesics. For somatosensory patients with palpable muscle tension, short courses of muscle relaxants or targeted analgesia may be symptomatic bridges while definitive dental or physiotherapy care is arranged. Nutraceuticals and supplements. Patients ask about magnesium, zinc, ginkgo biloba, or 5-HTP. Discuss these cautiously. Some small studies suggest modest benefit in particular contexts, but evidence is limited and inconsistent. If patients choose supplements, document it and review for interactions with other medications.
Steroids and hyperbaric oxygen. Reserve systemic or intratympanic corticosteroids and hyperbaric oxygen where available for confirmed acute cochlear injury, defined clinically by sudden tinnitus with corroborating audiometric decline. These interventions have a time-sensitive window where benefit is more likely. They are not appropriate for somatosensory-only presentations. Neuromodulation and device therapies. Hearing aids and cochlear implants are evidence-based for cochlear-related tinnitus when hearing loss is present. For cortical tinnitus, sound enrichment devices and structured sound therapy can be helpful adjuncts to counseling. Emerging neuromodulation modalities show promise in trials, but should be presented as investigational unless supported by robust local protocols. Behavioral therapies and practical defocusing. Cognitive behavioral therapy focused on tinnitus reduces distress and functional impairment. Encourage structured programs rather than ad hoc reassurance. Sound enrichment strategies, using environmental sounds, low-level masking at night, or hearing aid-based sound generators are practical defocusing tools and should be combined with psychological support when distress is high. How to manage mixed or overlapping presentations. Mixed presentations are common and require prioritization. Use the driver of distress principle. Which component is most responsible for the patient's functional limitation right now? If a patient has mild hearing loss and severe stress-related hypervigilance, prioritize counseling and sleep restoration while arranging audiologic rehabilitation in parallel. If a somatosensory nodulation is clearly changing the tone in one ear and that modulation aligns with a recent dental event, prioritize dental or TMJ interventions while offering counseling to reduce acute distress.
This dual-track approach, treating the primary driver while supporting the patient overall, is what interdisciplinary care should look like. Practical tools patients can bring tomorrow. Here's a 5-step checklist patients can use to prepare for an ENT or dental visit. These items make the first consultation far more efficient and raise the chance of a correct pathway being chosen. 1. Precise timeline. Write the exact date or dates the noise started. Any events immediately preceding onset, dental procedure, head and neck injury, illness, loud noise exposure, a period of intense stress, and whether the onset was sudden or gradual. 2. Laterality and modulation notes. Is the noise one-sided or both? Does it change with jaw clench, head position, or neck movement? If so, describe exactly how it changes. Gets louder, shifts pitch, disappears. 3. Hearing change and functional impact. Note any difficulty hearing in one ear, situations where hearing feels worse, background noise, and how the sound interferes with sleep, work, or relationships.
4. Audiology and imaging. Bring copies or dates of any audiograms, OPGs, or other imaging you've had. If you don't have copies, ask the clinic to send them before the appointment. 5. A short written objective request. I would like an audiogram, and based on my history of jaw modulation, a dental review and orthopantogram if you agree. Bring a printed one-page summary. Clinicians respond to clear asks. How to use TinniCare to speed the process. TinniCare was developed exactly to close the communication gap. It offers a clinician-facing diagnostic algorithm, downloadable one-page referral letters to give to dentists or ENTs, and short tutorial videos for patients on how to document modulation and pack an appointment-ready checklist. Use the TinniCare PDF letter as a template. It prompts the sender to include dates of onset, basic audiogram results, and modulation findings, and to request the most relevant imaging. Patients bringing that page to their dentist or ENT convert a vague concern into a focused clinical question, increasing the chance of effective collaboration. Interdisciplinary clinic models that work. Successful tinnitus services often blend ENT, audiology, psychology, and either dental or musculoskeletal specialists into a coordinated pathway. In one practical model, initial triage is done by audiology and ENT to classify into cochlear, somatosensory, or cortical pathways. Then a single clinic appointment bundles audiologic rehab, a brief CBT screening, and a targeted dental or physio referral if indicated. Where resources don't allow full interdisciplinary clinics, well-structured referral letters, shared audio documentation, and a named contact person who coordinates follow-up make a big difference. Red flags that require urgent escalation. Some findings should trigger immediate ENT or emergency referral. These are the situations where delay risks permanent hearing loss or a more serious underlying condition. Escalate promptly for sudden unilateral tinnitus accompanied by measurable hearing loss on audiogram, especially when onset is within 72 hours. Rapidly progressive hearing loss over days or weeks. New persistent pulsatile tinnitus synchronous with the heartbeat. Consider vascular causes and urgent vascular imaging. Focal neurological deficits, facial weakness, numbness, diplopia, focal limb weakness, or acute vestibular syndrome with severe prolonged vertigo and vomiting. Signs of infection, severe otalgia with fever, or rapidly worsening systemic symptoms. If any of these appear, document clearly, expedite audiometry, and arrange direct ENT assessment. Time-sensitive treatments exist, and early intervention can change outcomes. Common clinical pitfalls and how to avoid them. Pitfall: normal audiogram equals nothing to do. Avoid this. A normal audiogram does not exclude somatosensory drivers or central amplification. Use the 3 subtype framework and bedside modulation tests.
Pitfall: reflex steroid prescribing for unilateral tinnitus without audiometric evidence. Reserve steroids and hyperbaric oxygen for confirmed cochlear injury. Pitfall: over-referral for occasional physiologic somatic modulation. Not every modulation warrants dental referral. Prioritize cases with sudden unilateral onset, persistent modulation, and corroborating dental or TMJ symptoms. Pitfall: one-size-fits-all counseling. Tailor counseling to the subtype, defocusing and CBT for cortical, coordinated dental/physio care for sensory, rapid audiologic rehab for cochlear. Measuring outcomes and setting realistic expectations. Set goals collaboratively: reduction in distress, improved sleep, better function in noisy environments, or reduced frequency or intensity of intrusive moments. For cortical tinnitus, measurable outcomes often relate to anxiety scores, sleep quality, and functional scales, rather than total elimination of the sound. For somatosensory cases, partial or full reduction in perceived loudness may follow dental or physiotherapy interventions, but require time and rehabilitation. For cochlear cases, the goal of acute intervention is hearing preservation. Long-term goals include optimizing hearing amplification to reduce tinnitus impact. A final clinical checklist for the busy clinician. Ask the 6 key history questions in the first 5 minutes: timing, laterality, modulation, dental/neck events, hearing change, sleep/stress. Perform a quick modulation exam: jaw clench, jaw protrusion, head rotation. Order baseline audiometry promptly, document results, and compare with prior tests if available. Use the 3-branch flow: acute audiometric change, urgent cochlear pathway; unilateral normal audiogram plus modulation, somatosensory pathway; bilateral diffuse onset after stress, cortical pathway. Provide a clear written next step plan to the patient and a concise referral letter when specialist input is requested. Use short-term adjunctive medications only as bridges to definitive or supportive care. Bring the patient back for follow-up to reassess and coordinate interdisciplinary input as needed. The real shocking truth, revisited and reframed. The shock isn't that tinnitus exists or that it can be distressing. The shock is that many patients are assigned a single narrative, learn to live with it, without the focused diagnostic thinking that would reveal a treatable driver. That systemic gap is correctable. A few additional questions in the history, a short modulation exam, an orthopantogram when indicated, and better triage change trajectories for many patients. That's what Dr. Golenhofen's 3 subtype framework clarifies. It turns guesswork into hypothesis-driven care. Parting words for clinicians and patients. For clinicians, add the modulation test to your routine, use a 1-page referral letter, and remember the red flags that require urgency.
For patients, be prepared with the timeline, modulation notes, and a clear request for an audiogram and, where appropriate, dental imaging. Bring the 1-page checklist or the TinniCare PDF letter to appointments. It transforms conversations. You are not alone in this. Tinnitus is often the symptom of an identifiable problem, and many of those problems have targeted, evidence-aware treatments. The most important first step is a careful differential diagnosis. Once you know which driver is most likely, treatment becomes focused and measurable. If you want practical tools to take to your next appointment, download the TinniCare clinician letter and diagnostic checklist. Bring it to your ENT, audiologist, or dentist, and ask for the specific pathway that matches your history. With the right questions asked early and the right referrals made, learn to live with it can become, let's investigate and treat what's driving this.